So next is question number 1. A 24-year-old man, 75 kg man brought to ambulance by emergency room, found in local park. He is found to have a large left side groin abscess. Observation include a temperature of 35 degrees centigrade, heart rate 139, MAP is 47, serum lactate 4.3, hemoglobin 9.4, WBC 21,000. He has given initial bolus of 2 liter of Hartmann solution, MAP improved to 52, and his heart rate decreases to 124. Most appropriate next step: NORAD, further crystalloid, transfusion of packed RBC, administration of starch, transfer to theater for immediate wound debridement. Answer is A. Okay. Anything else? B. So the importance of the fluid resuscitation is that whenever you give the fluid resuscitation, you should continue fluid resuscitation till the patient becomes fluid unresponsive or patient's MAP increased to the 65 millimeter mercury. So in this case, they have given 2 liter of ringer lactate, but MAP is not achieved 65 millimeter mercury. That's why next step is to continue fluid administration. In practical, in our ICU, we used to start noradrenaline infusion, but theoretically, noradrenaline infusion should be started when the patient is not fluid responsive. Suppose we are doing some test to see whether patient is fluid responsive or not, and those tests are telling us that patient is on the top of the Frank-Starling curve, on the flatter portion of the Frank-Starling curve, there is no scope of giving further fluid, then only we should start with the noradrenaline infusion. So in the exam, if they have given this thing that patient has given some fluid, but still blood pressure is 52, and they are not saying anything about the fluid responsiveness. If in the same question they give you that patient is now not fluid responsive, then only we should start the noradrenaline infusion. So answer is B. Further crystalloid administration should be continued. Okay. Second question. 55-year-old woman with history of end-stage renal disease present to ED after missing 2 hemodialysis. Main symptom is the severe lower extremity weakness without evidence of volume overload. Urine output minimal since the initiation of RRT 4 years ago. Sodium is 126, potassium 8.5, chloride 93, CO2 17, BUN 65, creatinine 5.8. ECG showing peak T wave. 2 hours delay in the initiation of emergent hemodialysis. Which of the following has reduced the serum potassium most rapidly? So basically, this is a case of hyperkalemia. Is ECG also showing the same thing? And potassium is 8.5. So by which agent you will decrease the potassium most rapidly? Answer is B. Insulin and glucose. Okay. So correct answer is B. Correct. The range of potassium lowering after insulin and glucose therapy is 0.5 to 1.2 milliequivalent per liter. Okay. And calcium gluconate is only the thing which membrane stabilizer agent. It does not decrease the potassium concentration. It is just the membrane stabilizer. So it is the antidote of the potassium. And insulin decreases the potassium by shifting intracellularly. So that's why insulin and glucose is the very important thing to decrease the potassium level. Then regarding electrolyte administration of the adult of the following true except infusion of potassium should not exceed 40 millimole per liter per hour. Daily sodium requirement is 1 to 2 millimole per kg. Most calcium in extracellular fluid is protein bound. 1 gram of magnesium sulfate contains 4 millimole magnesium. Normal range of phosphate is 0.8 to 1.5. So what is your answer? Somebody wrote C. Absolutely correct. Basically, the 1 gram of magnesium sulfate contains 4 because the formula is MPC. M, when you convert the SI unit to the regular unit like millimole to milligram per deciliter, you should multiply by 4. Phosphate multiplied by 2.53 and calcium by 2. So 4, then 2.5, then 2. Okay. So MPC. Yeah, remember this thing. So maximum rate of potassium infusion should not exceed 40 millimole per hour. This may cause arrhythmias and asystole. Normal sodium requirement is 1 to 2 millimole per liter day. Extracellular calcium exists in 3 forms: 40% protein bound, 47% free ionized. So most common is the free ionized form, not the bound form. And 13% complex with citrate, phosphate, and sulfate. D and E are true. So I already told you the conversion factor of MPC. Then 24-year-old woman is brought to the emergency department by her boyfriend, who says he has not been acting like herself. He says no previous medical issue, does not take any medication. Febrile, BP 100/62, pulse 110. Patient is notable for dry mucosa, no acute abnormality, urine toxicology negative. CBC is normal. Sodium 140, potassium 4.3, chloride 110, bicarb 20, BUN 40, creatinine 2, and calcium is 18 milligram per deciliter. So basically, this is a case of hypercalcemia. The most appropriate treatment at this time. Answer is B. Okay. So hypercalcemic crisis. Please mute yourself. Please mute yourself. Hypercalcemic crisis in ICU. There are 2 DD. One is malignancy or hyperparathyroidism. Just a minute. I am taking 1 minute break only. Am I audible? Am I audible?
Yes, sir, you are audible.
Okay. So this is the case of hypercalcemic crisis. Whenever you find a case of hypercalcemic crisis or hypercalcemia in ICU, there are 2 DD should be in your mind. One is malignancy and another is hyperparathyroidism. So this is a relatively young patient, healthy patient. So along with the renal dysfunction, so you should think in terms of hyperparathyroidism. If this is an elderly patient with some evidence of malignancy, you should think of the malignancy. Usually malignancy is the most common cause of the hypercalcemia in ICU because usually in ICU the age group is elderly. That's why. But in this case, the DD is hyperparathyroidism, and IV resuscitation along with the diuretic is the most important therapy for the decreasing the hypercalcemia. Calcium mimetic agent like cincalactin reduce calcium level by activating calcium sensing receptor in the parathyroid gland. Glucocorticoids usually secondary to granulomatous disease, but they take around 2 days to show the benefit. Bisphosphonate like zoledronic acid, these acts by inhibiting calcium release by interfering osteoclast mediated bone resorption. So hypercalcemia in ICU is very important topic. You should read in detail because they usually ask questions from the 4 electrolytes. One is sodium, another is potassium, and then third number calcium, and fourth is the magnesium. So these 4 electrolytes are very important in the exam, or especially sodium, potassium, and in third number calcium. So a 35-year-old woman with a history of diabetes, hypertension, lupus is admitted to ICU with concern for pneumonia and severe sepsis. Her home medication include methotrexate, hydroxychloroquine, prednisone, esomeprazole, lisinopril, metformin. Initial lactate level is 5. She is started on broad spectrum antibiotics and given 3 liters of IV normal saline. Despite continued aggressive fluid resuscitation in ICU, her blood pressure decreases and started on norepinephrine and low dose vasopressin. She is on 6-liter nasal cannula with oxygen saturation of 95%, blood pressure 80/40, pulse 120 beats per minute, respiratory rate 22. Laboratory assessment shows a lactate of 3 millimole per liter, hemoglobin 10, and central venous oxygen saturation 70. Central venous pressure is 12 and urine output is adequate. Which of the following is the best next step in the management? Order an additional 2 liter IV bolus or add antifungal coverage, start IV stress dose steroid, and start epinephrine. What is the diagnosis here? Patient was on the prednisone because of the lupus. This is the catching point. So this is the diagnosis is the CIRCI, critical illness related corticosteroid insufficiency. So whenever a CIRCI is there, so you will not get the result until unless you don't give the steroid. So there is a suppressed HPA axis, and despite giving appropriate fluid resuscitation, antibiotic, vasopressor, patient remains in refractory shock. So patient needs an IV stress dose steroid to support the blood pressure. And the survival sepsis guideline also suggests that if patient is already on the steroids or you are not getting the result after the adequate fluid resuscitation and vasopressor is required, you should add the stress dose IV steroids. And the most common agent is the hydrocortisone, 200 milligram IV once a day, or you can use the 50 milligram Q6 hourly. So woman with Burkitt lymphoma is admitted to the ICU 48 hours after initiation of cytotoxic chemotherapy. She is febrile, vomiting, and lethargic. TLS is suspected, tumor lysis syndrome, with hyperkalemia, hyperphosphatemia, hypocalcemia, and hyperuricemia. Which of the following medication used to prevent hyperuricemia as a complication of cytotoxic chemotherapy? Phosphate binder, recombinant urate oxidase, xanthine oxidase inhibitor, purine analog. So what is the treatment? Somebody told C. Okay. So answer is B, recombinant urate oxidase. So TLS, I am not going in much detail of TLS because this is very important, high yield topic in the exam. You should read the electrolytes. Only calcium is low, others are high, like potassium is high, phosphate is high, but the calcium is low. One thing. Second thing, the treatment, the xanthine oxidase enzyme catalyze the formation of uric acid from xanthine and hypoxanthine. So uric acid is excreted in the urine, but higher level leads to precipitation and crystal-induced nephropathy. So you should use this thing, the recombinant urate oxidase, resburicase. Okay. Next is the K-type questions. Regarding fluid used for resuscitation, transvascular exchange of fluid is determined by hydrostatic and oncotic pressure across capillaries and interstitial space. The structure and function of endothelial glycocalyx layer is a key determinant of membrane permeability in pathophysiological states. Fluid resuscitation with bolus of albumin or saline in febrile children with poor perfusion associated with improved outcome. Use of hydroxyethyl starch may be beneficial in early sepsis. Albumin use associated with increased mortality among patients with traumatic brain injury. So what are options are true and false? Only fourth is false according to someone FTTF. So answer is the B and E are correct. The structure and function of endothelial glycocalyx is a key determinant of membrane permeability, and albumin use associated increased mortality among patients with traumatic brain injury. So this was the result of the FEAST trial. There are two trials of the albumin. One is SAFE trial, another is a FEAST trial. So in the FEAST trial, they have shown the increased mortality in the patient of traumatic brain injury. That's why albumin should not be given to the patient with traumatic brain injury. One thing. Second thing, the endothelial glycocalyx layer is the key determinant of membrane permeability in the pathophysiological states. And HES may be beneficial in early sepsis. This is wrong. Fluid resuscitation bolus of albumin or saline is associated with improved outcome. This is the SAFE trial. In SAFE trial, they have shown fluid resuscitation with either bolus of albumin or saline is the same outcome. There is no improved outcome with the albumin or saline. So starch-based IV fluid are derived from bovine collagen, lowest risk of anaphylactic reaction, are safe in critical care patient, are associated with increased need for dialysis in critically ill. It occurs in up to 13% of patients receiving starch-based IV fluids. So what is your answer? Somebody has given TFFTT. Okay. So answer is the D and E are correct. Rest are wrong. So derived from bovine collagen, no, this is derived from hydrolyzed maize. And have the lowest risk of anaphylactic reaction, no. Are safe in critically ill patient, no. They causes the AKI. Increased need for dialysis in critically ill, yes, they cause AKI and they increase the need for dialysis. Itch occurs in up to 13%. Yes, there is a itching occurs in 13% of patient with who receive the starch IV fluids. Hartmann solution contains 131 millimole of sodium, 4 millimole of potassium, 154 of chloride, bicarb, 9 kilocalorie energy in 1 liter. So you should know the components of the fluids like Hartmann solution or Ringer lactate or some normal saline, how much chloride is there, how much sodium is there. You should know these things. So answer is true A and E. Sodium is 131 and 9 kilocalorie energy in 1 liter. Potassium, there is a 5 millimole of potassium, so chloride 111 and metabolized via pyruvate to glucose. It does not contain bicarb. So Hartmann solution or Ringer lactate does not contain the bicarbs. So you should read these are the theoretical questions, but they ask these type of question in the exam. 0.9% saline contains the same sodium concentration as plasma? No. Is isotonic compared to chloride restrictive fluid? The use of 0.9% associated reduced renal replacement therapy need can produce a hypochloremic metabolic acidosis, may cause abdominal discomfort. So answer is B and E. Isotonic होते हैं ये and may cause abdominal discomfort. But can the hypochloremic metabolism? No, these causes the hyperchloremic metabolic acidosis. Okay, so and they don't contain the same sodium concentration as plasma because sodium is 154 and chloride is again 154. So plasma, the sodium concentration is around 144. So it's high. Human albumin solution is derived from plasma from one donor. 4.5% is hyperoncotic, 20% is mildly hypotonic. Improved outcome in critical care have been found with use of human albumin saline compared to saline. May have an outcome benefit when used post-ascitic drainage. So what is your take? So answer is C and E are correct. 20% is mildly hypotonic and E may have an outcome benefit when used post-ascitic drainage. Okay. So this is derived from plasma from multiple donors. 4.5% is isooncotic and 20% is hyperoncotic. Okay. So 20% is hyperoncotic, 20% is hyperoncotic but salt poor. So mildly hypotonic. So there is a difference between the hyperoncotic and hypotonic. So they are saying that 20% is low salt albumin, salt poor albumin. That's why it is mildly hypotonic. But as a osmolarity, it's a hyperoncotic. So you have to understand this thing. Safe study, I already told you that there is no difference between when they use the crystalloid comparison to the albumin. There is no difference in the survival outcome. And human albumin solution may outcome benefit when used post-ascitic drainage. So this is the class 1 indication of the albumin. There are 2-3 class 1 indication. One is the you should use as a post-ascitic drainage. The second thing is SBP, spontaneous bacterial peritonitis, and third is the HRS, hepatorenal syndrome. So these are three class 1 indication of the human albumin solution. Then detection of fluid responsiveness. Clinical assessment is of good value for detecting fluid responsiveness. Static markers of preload. Somebody is a repeat. Sorry, I have to go back and tell you that it is derived from multiple donors. Indications only. Okay. So indications of that albumin, human albumin solution are three class 1 indication. One is HRS, hepatorenal syndrome. Another is the post-ascitic drainage. Third is the SBP, spontaneous bacterial peritonitis. Then we will move on the next question. Detection of fluid responsiveness. Clinical assessment is of good value for detecting fluid responsiveness. Static markers predict reliably. Variation in arterial can predict fluid responsive ventilated patient. Arterial pulse pressure variation cannot be used to assess fluid responsive spontaneously breathing patient. And PLR aid prediction of fluid responsive spontaneously breathing patient. So clinical assessment is not a good value in detecting fluid responsiveness. The most important thing is the dynamic parameters. What is the dynamic parameters? Like PPV, SVV, and the static parameters like CVP or the PAOP. They doesn't tell us reliably the prediction of fluid responsiveness. And for PPV and SVV, the most important thing, patient should be paralyzed, patient on the ventilatory support, and tidal volume should be more than at least 8 ml per kg. So in ARDS patient, you cannot use these parameters. But passive leg raising can be used in a spontaneously breathing patient as well as the mechanically ventilated patient. So PPV and SVV should be used only in the ventilated patient, not in a spontaneously breathing patient. So A is wrong, B is wrong, C is correct, D is false, and PLR is correct. So the answer is C and E are correct. C, D, E are correct, and first 1 and 2 are wrong. Okay. Then preload status. Transmural pressure is proportional to cardiac chamber dilatation. Cardiac transmural pressure is difference between intravascular and extravascular pressure. CVP is a good preload index. GDVI represent blood in heart chamber only and is normally 650 to 800. ITBVI is measured directly. So this is advanced hemodynamic monitoring. So the parameters ITBVI, GDVI, these are the pico parameters. Answer is A, B, D are true. Transmural pressure is proportional cardiac chamber dilatation, true. Cardiac is the difference between intravascular and extravascular pressure, true. And then GDVI, the normal value is a 700. So 650 to 800 is correct. CVP is a good preload index, no. CVP is a static parameter. And ITBVI is a calculated parameter. It is not measured directly, because it's a GDVI multiplied by 1.25 is the ITBVI. Okay. So this is a calculated parameter. This is not measured directly. In relation to sodium, sodium is the principal cation of the intracellular fluid. Criteria for the diagnosis of SIADH includes finding a urinary sodium less than 20. 1 liter of 3% saline sodium chloride contains 500 millimole of sodium. Hypernatremia is always associated with hyperosmolality. Normal serum osmolality is 285 to 295. You should read each and everything about the sodium, potassium, and calcium. These three electrolytes are very important in the exam. So, what is your answer? What is the formula of the osmolality? 2 into sodium plus BUN upon 2.4 plus glucose upon 18. So basically, sodium content is directly proportional to the osmolarity. So hypernatremia, answer is C and D. So hypernatremia is always associated with hyperosmolarity. So this is correct. 1 liter of sodium chloride contains approximately 500 millimole of sodium. So 513 millimole of sodium. So it is also true. Third is sodium is principal cation of the extracellular fluid. Urinary sodium is more than 20 in SiADH. Okay. So SiADH and CSW, these two things, the difference between these two things are very important. And by the urinary sodium or serum osmolarity, urine osmolarity, you cannot differentiate between the SiADH and CSW. For differentiation of these two entities, you have to see the volume. If patient is hypovolemic, then diagnosis is CSW, cerebral salt wasting syndrome. If patient is euvolemic, the diagnosis is SiADH. Okay. Then hypertonic saline. 7.5% sodium chloride contains 1283 millimole of sodium, draws intracellular and intracellular water into intravascular space, decrease cerebral swelling and ICP. 250 ml of 7.5% sodium chloride inadequate initial resuscitation dose may cause severe hyponatremia. Anybody? So true is A, B, C is true. 7.5% contains 1283 millimole of sodium, draws interstitial and intracellular water into intravascular space. That's the thing by which it works in the reducing the ICP from the brain tissue and decreases cerebral swelling and ICP. That's why hypertonic saline is used in the raised ICP. 250 ml is an adequate initial resuscitation dose. No. May cause severe hyponatremia. No, it causes hypernatremia. So 250 ml may be adequate for initial resuscitation dose. So and it causes severe hypernatremia. Hypernatremia is most often due to unreplaced water loss from GI tract, sweat or urine. Over rapid correction of hypernatremia, especially if chronic in onset, can result in brain edema. Hypovolemic patient with hypernatremia should initially be managed with hypotonic solution. Central DI is caused by kidney failing to respond correctly to antidiuretic hormone. In patient with nephrogenic DI, desmopressin is the treatment of choice. So what is your answer? Somebody told TTF, only C is wrong. Okay. So true A and B are true, C, D, E, all three are wrong. So hypernatremia is most often due to unreplaced water that is lost from GI tract, skin or urine. In chronic hypernatremia, aim for reduction in serum sodium content less than 0.5 millimole per liter per hour. Then hypovolemic patient with hypernatremia should initially be managed with isotonic solution. This line is very important even in the clinical practice. Sometimes we find the patient with hypernatremia and hypovolemia, but we start with the D5 or half NS. In those cases, even with the hypernatremia, if patient is hypovolemic, you should start with the isotonic solution or normal saline. Central DI is caused by a condition of hypothalamus or pituitary gland if there is deficiency or amount of ADH. Patient with central DI, synthetic analog of ADH like desmopressin is the treatment of choice. It is available in oral intranasal. It is known as Minrin puff. So we use an intranasal desmopressin for the DI patient, diabetes insipidus. So I am stopping here. So I have tried my best to give you the important high yield topics related to these fluids and electrolytes and trauma and burn, as well as some general topics which includes the antibiotics, which includes the GI system, upper GI bleed, or Sengstack black tube, or some other topics also. So I am stopping here. If you want to ask any question, you can ask.